Welcome. This is Mary D'Onofrio. I'm Director of the Fetal Heart Program here at Children's National, and it is my extreme pleasure to introduce perhaps one of the smartest people I know for sure, and definitely most dedicated. Anita Moon-Grady is a professor of pediatrics and director of the Fetal Cardiovascular Program at UCSF, and she's going to tell us about fetal cardiac interventions.
All right. Well, thank you, Mary. Thanks for inviting me to speak. I am a little bit more comfortable in front of a big audience than on a webinar, believe it or not. So I'll do my best, but this is a little bit new forum for me. So I was asked to talk about fetal cardiac intervention, in particular how it may change outcomes in congenital heart disease. And as I thought about that a little bit more, I wanted to also bring up some questions about change versus improvement. So we will talk about it in that context. Now, this is sort of the classic debate that we have in fetal cardiology. It's always entertaining to put people on a stage and have them debate the pros and cons of fetal intervention. And the usual pro is it prevents hypoplastic left heart syndrome. The con, it doesn't work. And I think it's time to really get over this argument. It's over 20 years old, and we have amassed a lot of data. And so that's what I want to present today. First, then, this concept of improving versus changing outcomes and who we are trying to improve outcomes for. And then I will present some fetal cardiac intervention current applications and published data, and all along the way, perform a critical appraisal of this data and where we need to go next. So first, this defining of change and improvement. And before we can even define improvement, we need to define who we are trying to improve things for. Is it for the patient? And if so, who is the patient? Are we trying to improve things for the pregnant woman, for the woman herself, or for the pregnancy, or for the baby? And we get into issues, ethical issues of autonomy versus selflessness that as prenatal care providers we deal with every day, but this certainly is a serious ethical issue. For the fetus, maybe we can improve things for the fetus or for the child, and keeping in mind that defining improvement for the child takes into account the context of the healthcare delivery system into which they're being born, the family into which they're being born, and their resources. And so that also brings up this issue of who is the patient. Is it the family? And is improvement or change for them something that we need to discuss as well? So a very complex ethical issue for all of us that, as I said, fetal centers deal with this every day. Again, I want to back up, though. Why is this even an issue? We have perfectly good treatment for congenital heart disease these days, right? We have developed single ventricle palliations, including the single ventricle palliation to Fontan, which I have outlined on the following slides just for people who don't look at this every day. The Norwood operation involves reconstruction of a neo-aorta from the pulmonary artery and whatever is present of the aorta with a right ventricle to pulmonary artery conduit supplying pulmonary blood flow. Then a second stage, as the child grows at about 3 to 6 months, the right ventricle to pulmonary artery conduit is taken down, and an anastomosis between the superior vena cava and the pulmonary arteries to provide pulmonary blood flow is performed. Then when they are toddlers, 2 to 5 years of age, they'll have total cavopulmonary connection or Fontan completion, in which they still have that bidirectional glen, but now the inferior vena cava is routed via, at our institution, an extracardiac cortex conduit to the pulmonary arteries, completing the Fontan circulation. In some places, this is done by a lateral tunnel. So this is a lot of surgery. Leaves you with your aorta. And the timeline for these single ventricle patients really can be thought of as extending from the prenatal period onwards to the Norwood that they have, and will be discharged from the hospital at about a month of age, back in the hospital 3 to 6 months for the bidirectional blend, Fontan at 2 to 5 years, teenage years, they may start to have increasing medical problems, and as adults, the vast majority who are still alive do have some issues, and beyond that, outcomes are a little bit less well defined. So this timeline that starts in the prenatal period doesn't necessarily have a defined sort of outcome that we can fix. So while there is neonatal therapy for hypoplastic left heart syndrome, it's not really as cut and dried as that. We don't have a fix for this. In fact, in the single ventricle reconstruction trial, it was noted, this was a randomized controlled trial of one type of shunt versus another, and that's not important for this. What's important is that this is a relatively recent era randomized controlled trial in some of the best surgical centers with the best follow-up. And as we all know, patients in trials do tend to do better than so-called historical controls. So the best possible scenario, and still at 4 years of life, there was only a 60 to 70% survival in this cohort of hypoplastic left heart syndrome patients. So not all good news. There are variants of hypoplastic left heart syndrome with restrictive or intact atrial septum, left atrial hypertension in utero that can make them even more high risk and make their survival much less than the standard HLHS patients that I just presented with, shown on the right-hand side of the screen, muscularized pulmonary vasculature and pulmonary hypertension. This entity of restrictive interatrial septum complicates the immediate postnatal management, makes them very unstable upon separation from the placental circulation. And even if they survive their initial resuscitation, that pulmonary vascular disease may preclude single ventricle palliation, leaving the infant who survives the immediate postnatal period subsequently inoperable. So very serious comorbidity with hypoplastic left heart syndrome. So as I've outlined, the single ventricle palliation isn't exactly transformative. What about pediatric or neonatal heart transplantation? Well, this too has good short-term survival, but longer-term survival in a cohort of pediatric heart transplant patients. This is from a few years ago, but was only 40% at 20 years. The issues with pediatric orthotopic heart transplantation include rejection, which is a lifelong issue, infection as well, allograft vasculopathy, malignancy, and post-transplant lymphatic diseases, renal disease, and an almost universal need for retransplantation. And so just as an example of one of these complications, the freedom from first episode of rejection is shown in the graph. At 10 years, more than half of patients have had at least one rejection episode. And so to sort of overview or sum up the current available postnatal palliations for hypoplastic left heart syndrome in particular, we have surgical options. Short-term outcomes are good, but longer-term outcomes are less clear. And just to mention a few others that are not directly related to surgical survival, but related to the longer-term survival. This is a a great hypoplastic left heart syndrome patient who's had their Fontan, the extracardiac conduit is there, just a little bit of regurgitation, good function. But here's another patient who's just status post-Glenn with very poor right ventricular function. So ventricular function is something that's sort of an intrinsic problem with the Fontan circulation and these patients. Some of it may stem from prenatal dysfunction that's not very well understood, but as the years go on, ventricular dysfunction becomes more and more of an issue. They also have arrhythmias, protein-losing enteropathy, hypoxemia, endocarditis, exercise limitations, elevations in PVR, thromboembolic complications, hepatic dysfunction, and complications from long-term cyanosis. So this is, in the patients who survive, everything I showed you before were just survival curves, but survival with significant morbidity in some. There's data on exercise physiology declining with age that I'm not going to go into. There are also, I don't need to tell this audience, issues with neurodevelopment that's probably multifactorial. And heart failure and thromboembolism, ventricular failure at 10 years plus post-Fontan is almost universal, and thromboembolic complications increase at over 15 years post-Fontan, which sounds like, a long time after Fontan, but remember, these kids are 2 to 5 years old when they're having these. So you're talking about young adults looking at going to college, starting to have profound issues with ventricular failure and thromboembolism. They also have, at this point, problems with arrhythmias, and another complication that is almost unique, not entirely unique, but almost unique to Fontan population is, excuse me, plastic bronchitis, which is illustrated here. These casts of proteinaceous material that deposit in the airways, and this is something that can be absolutely devastating. Protein-losing enteropathy, the second to last long-term complication of Fontan palliation. Historically, even though it only affects between 1 and 10% of Fontan patients, has a very dismal prognosis with 50% 5-year survival and 75 I think that's a mistake, 25% transplant-free survival. And another, the final complication from our Fontan population that we're just beginning to recognize as they are surviving longer is Fontan-associated liver disease, which may necessitate both heart and liver transplant in their 3rd and 4th decade of life. And so it is an issue that if we could potentially intervene in fetal life to improve outcomes for these patients, to change their outcome at least from hypoplastic left heart syndrome to something that allows them to have a biventricular circulation, that maybe they won't have all of these complications. So let's look at the data. There are several single-center publications out there for fetal aortic stenosis. I'll talk about aortic stenosis and a little bit about atrial septal intervention. I'm not going to talk about pulmonary valve disease. But as far as intervention for aortic stenosis, there's single-center data, there are multi-center data from Europe, and some issues that I'll go over with each one of these studies. But first, just to introduce the concept, if you haven't seen this, fetal aortic valvuloplasty is now done via percutaneous access through the maternal abdomen, uterus, and then a perventricular approach to the fetal left ventricle. Here's one of our patients. There's the needle going through the uterus and then puncturing through the left ventricle. And then a balloon-tipped catheter is threaded through the needle and inflated across the aortic valve. This is sort of off-the-shelf balloon catheter for PCI, and I guess I'm supposed to mention this is not exactly the labeled use of this product, but it is labeled for intravascular use, and so the use of it is allowed. Here's a different patient of ours from UCSF who had a successful intervention, dilated, poorly functioning left ventricle as a fetus, and after 9 months in a Roscono operation, has a normal-sized left ventricle at least, although there's some diastolic dysfunction there. So I mentioned that there are single-center data. The two biggest centers are Boston and Linz, and they've both published extensively on this. The Boston group published a follow-up to their initial report. This follow-up, first authored by Lindsay Freud, who's at Columbia now, talked about the outcomes of the first 100 patients. Of those first 100, there were 38 who were biventricular at the time of publication, 31 who were biventricular from birth, and 11 procedure-related losses. They had almost no cardiac deaths in their biventricular final circulation and no cardiac deaths if the patients were biventricular from birth. So that's the graph on the right. Linz published their first 24 procedures several years ago now, where 2/3 of their patients were biventricular. And in addition, they showed that left heart obstruction with hydrops responded favorably. They had a similar fetal loss rate, about 10%, and also reported a significant number of patients, over half, had some sort of complication that did not result in death, so treatable bradycardia, pericardial effusions. The newer Boston data has also been published. Kevin Friedman just recently published separating their experience out to the earlier versus later era with much better success rates in actually getting the balloon inflated across the valve, and a much higher, almost 60% of patients were live-born with biventricular circulation, probably because of more refined patient selection. And that was shown here graphically. They did a recursive partitioning analysis, CART analysis, to show that the patients with higher left ventricular pressure and larger aortas at the time of fetal intervention were more likely to have a successful intervention. So it's all looking pretty good so far from that single center data, at least from Boston and Linz. But to look at the sort of counter argument, the Association of European Pediatric Cardiologists Fetal Working Group in 2000, in the mid-2000s, put together a multi-center study. This was a two-part study, so I'll present first the natural history study, where they had 107 fetuses who did not have fetal cardiac intervention, but they went back and sort of retrospectively applied the so-called Boston criteria to identify ideal candidates. And then they looked at their survival and their final postnatal circulation. They found that of the 40 who met the criteria for LV length, retrograde flow across the atrial septum and arch, of 40 who met criteria, 33% of those were actually able to have a biventricular repair without fetal cardiac intervention. And in addition, 42% of the patients who were worse than Boston's threshold score of presentation were also biventricular. So a significant number of patients who would, if they had undergone fetal cardiac intervention, would have been biventricular, but the Europeans argued they would have been biventricular anyway. Now, as part of the same study, they then also had patients who had fetal cardiac intervention. There were 59 of these. 40% of those were biventricular from birth, and graphically the follow-up is shown in the chart on the right, with survival versus follow-up from birth. And the fetal valvuloplasty patients look like they're surviving better than the natural history cohort, but if you separate out the fetal valvuloplasty who had a univentricular circulation, so a essentially failed procedure versus a successful procedure, it's the univentricular patients who actually are driving that difference. And so given they also had a 10% loss rate, which isn't shown on this curve, and a significant prematurity rate, it's questionable whether this procedure is actually providing patients with better improved outcomes, although it did seem to confer a survival advantage in the univentricular patients, which is sort of curious. So mixed data then from the European group. A lot of other smaller papers have been published. Argentina had most of their procedures successful, but most of their losses were postnatally because they are unable to, at least at the time of this study, were unable to provide single ventricle palliation and didn't have great neonatal surgery, so they all died postnatally. Groups from Spain and other groups in South America have also published smaller series. So what about longer-term outcomes then? The Boston group, again, has published a high rate of reintervention in those first 100 patients. The oldest one, I think, was 10 years old when they published that, with a high prevalence of pulmonary vasodilator use. And neurodevelopmental outcomes have not been shown to be better. So putting all of this data together, it does seem, even the European group agreed that you're able to change the natural history of disease with a fetal valvuloplasty, but is it actually doing them any long-term good? These are the, not to read this, but from that paper from Boston looking at long-term outcomes, a long laundry list of additional surgical procedures that the patients have undergone. The vast majority of the so-called successful patients have had additional surgical procedures, some of them multiple surgical procedures. And to go into why that is and maybe put a little bit of context on that, I would say that most of these patients are still born with aortic stenosis, even if they aren't born with hypoplastic left heart syndrome. And the treatment for aortic stenosis in infancy is also balloon aortic valvuloplasty. But many patients end up having this procedure, which is a Ross procedure. It's moving the pulmonary valve, which is normal, into the aortic valve position. So giving the patient a neo-aortic valve and then giving them a right ventricle to pulmonary artery conduit. This is a pretty big neonatal operation as well, a neonatal Roscono operation. And even balloon valvuloplasty does leave patients with some residual morbidity. The mortality, early mortality is not that high for neonatal aortic stenosis, but the long-term mortality is significant. This paper from Dov McElhenney reported 14% early deaths in a neonatal aortic stenosis cohort, and also found that even though transcatheter aortic valvuloplasty is effective in congenital AS, there are steady long-term hazards for surgical aortic valve reintervention and replacement. And so the way that I look at this is that a successful fetal valvuloplasty sort of sets you up for having a patient with aortic stenosis as a neonate, and their outcome may be different from those with hypoplastic left heart syndrome, but it's still not clear that it's all that much better. There's a survival issues, and then there are long-term issues with pulmonary hypertension, need for multiple reoperations. So if the two then, the fetal intervention versus natural history, each have their own advantages and disadvantages, one might ask, well, why not do a randomized trial to see which one's actually better? And I usually counter this argument with the cost and logistics of doing a large randomized controlled trial for this very rare disease in fetal life. The incidence of this is similar to myelomeningocele, and as some of you may know, the MOMS trial, which looked at fetal surgery versus postnatal surgery for spina bifida, took over over 8 years and something like $6 or $8 million of NIH money in order to show a difference for fetal surgery. So while it was great for fetal surgery, it was a huge labor of love, and I don't see the NIH funding another study like that in the fetal realm. So cost, logistics, there also is this issue that there's a variability in postnatal approach and care, as I showed with the Argentinian group who had successful valvuloplasties, but their neonates still died because of the availability of care. And then finally, we've been at this now, at least in Boston, since 2001, and there really is a lack of equipoise. There are people who really believe that fetal intervention works, and so randomizing patients would be quite an issue. So why then a registry? Well, for all of the reasons above. A lot of other areas we are moving towards registries. They're very common in the congenital cardiac world, and they're at least less costly and more feasible, even though they give you different information. So we established in 2010 the International Fetal Cardiac Intervention Registry. It's housed here at UCSF. We currently have over 20 centers entering data. And, this slide is from last year. We now have 648 records. The majority of those patients underwent intervention. We ask that all patients who are offered intervention be put into the registry, or at least the ones that are being evaluated for intervention. And then we're recording procedural details and pregnancy outcomes. Our first publication was in 2005. At that time, only 2 centers were still requiring research consent, speaking to the lack of equipoise. 8 centers considered this to be clinical care. Most of the procedures by 2010 were being performed percutaneously, with almost no one doing laparotomies and no hysterotomies anymore. Most of the procedures are being done without general anesthesia. There had been an evolution from general anesthesia to either local or spinal epidural. And so this just shows you some things that we can learn from the registry about evolution of the procedure towards better and better safety and less morbidity, at least for the mother, with percutaneous access and avoiding general anesthesia. Fetal cardiac intervention for atrial septal restriction, I haven't mentioned very much, but this is a similar approach, a percutaneous approach to deploy a stent across the atrial septum. It does have a different goal of decompressing the left atrium and allowing for a more stable neonate and potentially for giving time for reversal of those pulmonary vascular changes that I showed you. Boston, Brazil, and Toronto have all published small series of data. This is a video of a fetal patient undergoing stent placement. I'll just let that play for a second. So the stent is actually in the lower right, lodged in the atrial septum. And there is color flow demonstrating pulmonary venous return to the right atrium. And the pre and post pulmonary vein Dopplers, these are both done in the operating room, one immediately before and one immediately after the stent deployment. So it does seem to be feasible. We've also looked at these patients through our registry approach. And Trey Jansen, when he was in Michigan, published this in Circulation last year. At that time, we had 46 fetal cardiac intervention patients, including 19 stents, and the rest of them were just balloon dilations of the atrial septum. We showed disappointingly no difference in overall mortality, but did show a high procedural success. No difference between septoplasty and stent, but the stents were more likely to stay open until delivery. Fetal complications were frequent, but not often fatal. And if there was a procedural success and the fetus survived the procedure, there was improved neonatal stability and a trend towards better 30-day survival. What about maternal outcomes? I did start this, this talk saying that it's not just all about the fetus and baby. We know from experience with all types of maternal-fetal procedures that complications are a concern, but not all that frequent, especially in percutaneous types of procedures. So this was a paper from 2006 from a single institution, it's actually from UCSF, of about 200 patients and procedures where most of the maternal complications were in the hysterotomy group. There were no deaths, but a significant number of women had pulmonary edema and even needed ICU care. Chorioamniotic separation, preterm labor, preterm delivery were also common, even in the percutaneous procedures, but a lot of these were percutaneous sort of hysteroscopic type of procedures, not needle-based procedures. So, so there are complications associated with maternal-fetal procedures in the mothers, including all of the above and fetal loss. Christoph Wellmuth looked at data from another institution of all percutaneous procedures, 53 of them, with, again, no maternal deaths, no major complications, but postoperative pain, bleeding necessitating transfusion, and pregnancy loss are about 10%. And so combining this experience, this published experience, and other centers, I think, would agree that our general counseling for percutaneous fetal procedure is about a 10% pregnancy loss rate can be expected, and additional concerns for mothers, but no recorded maternal deaths yet. Well, we looked at this atrial septal intervention group a little bit more closely with maternal complications in mind, and found that our need for impact or exit procedures and for C-sections was actually less in the fetal cardiac intervention group. So that was an interesting finding, that potentially we can be improving and changing the outcome for the mother while we are also trying to improve the outcome for the fetus. Also from that graph, I just want to point out that neonatal resuscitation and preoperative ventilation were also lower in the atrial septal intervention group. And if you think about a patient, a fetus with intact or highly restrictive atrial septum, and I tell you that they only have a 50 to 60% chance of needing to be intubated at birth, this is actually a real, I think, proof of concept that the fetal intervention can improve stability. We just weren't really able to show that because of the numbers in this study. It was a difference, but not statistically significant. So where are we now with this concept then of the fetal interventions for cardiac disease overall? Are they a good idea? Are they not a good idea? Do we improve outcomes for the fetus or for the mother? There are schools of thought about fetal therapy. I did mention ethics earlier in the talk, and I wanted to bring up this article from 1982 where Mike Harrison and some of his colleagues in the fetal therapy world published in the New England Journal of Medicine some general guidelines of maternal-fetal interventions. We recently rewrote these guidelines in the context of the current era, pointing out that when undertaking maternal-fetal therapy, we have to first consider maternal safety and autonomy, and then have the necessary expertise and systems base for provision of these interventions, including care for the mother after intervention if there is a complication. Transparency and reporting was another basic tenet and criteria for ensuring advancement and innovation, so that we don't sort of squash innovation by always insisting on randomized controlled trials, but also ensuring that this is done in a safe, scientific, and transparent way. We also need to continually consider training of new generations, and also recommended that that detailed recommendations for center infrastructure need to be agreed upon very soon, before really maternal fetal intervention takes hold and is starting to be done in centers that are not providing appropriate infrastructure. So to come back then to this idea of changing or improving outcomes for fetuses with congenital heart disease, left heart obstruction, and defining improvement, now using the data. Again, the pregnant woman has issues of safety and autonomy. We do need guidelines, but we do have some safety data, and as we're moving towards less and less invasive, more percutaneous procedures without general anesthesia, things are improving, but there's still work to be done. As far as the fetus is concerned, are we improving things for the fetus? We cannot get probably better than 90% survival because of that 10% peri-procedural risk associated with the fetal procedures. There's little in the way of analysis of volume outcomes relationship beyond just fetal death, fetal complications. And so one of the next registry efforts is actually to look at those 600 plus interventions and see where the learning curve is, and if there should potentially be centralization of procedures to minimize those complications that I reported. For the child, we have really no data about this context issue and the ability of the healthcare system to deliver postnatal care for the single ventricle palliation versus Ross. And so more work needs to be done there as well in standardizing postnatal care. Defining outcomes before we can assess for improvement, I think, is key. We have to decide what it is we're trying to improve, or are we simply talking about different options? Is the Ross-Kono operation in a neonate with pulmonary hypertension and uncertain long-term survival and outcome, is that really better than a Norwood Glenn-Fontan pathway? We just don't know yet. So we have to define, and maybe that definition of improved is going to be different for each family. So I would say that changing outcomes, we definitely can change them, but improving outcomes is not quite clear. So to sort of summarize that pro-con argument, for aortic stenosis, the pros now are that it does give you the potential for avoiding Fontan. It's easy in experienced hands. There is very little maternal risk, and it may confer a survival advantage even if it's not successful. It certainly is innovative and fun. On the other hand, successful patients still have aortic stenosis. There's a 10% fetal loss rate. There is some maternal risk, and there are unknown effects on neurodevelopment. We're assuming that it's equivalent, but we don't know that yet. Hasn't been systematically studied. As far as the intact or restrictive atrial septum, the pros, well, these are really, really poor candidates for Norwood palliation, and long-term survival is in some series less than 10%. And so there seems to be little downside to an attempt at a fetal intervention. It is feasible in experienced hands, but not easy. It may allow for a vaginal delivery. That was the one thing that we showed, a decrease in the number of C-sections. It may confirm a survival advantage in the longer term. It's unclear, and again, it's certainly innovative and fun. The downside, the patients still have hypoplastic left heart syndrome, so you're trying to take a bad hypoplast, turn them into a good hypoplast. There is a fetal loss rate, stent embolization can't be dealt with in these fetuses, and there's probably a little bit more maternal risk, especially for bleeding with longer operative times. There's no difference been shown in short-term survival, and again, not systematically studied. And so overall, what I'd want to leave you with is that maternal fetal intervention for fetal cardiac disease deserves attention to the emerging standards for care delivery. Certainly a lot of places worldwide are doing these procedures. Continuing investigation, though, is necessary of both. We still don't completely understand the natural history of the defects, nor the outcomes, the so-called unnatural history after intervention, both short and long term. Transparent reporting of outcomes for both patients, the mother and the fetus, are remaining necessary. And the good news is collaborative efforts and iterative approaches to improvement in candidate selection, technique, and definition of success are underway and are possible in today's medical world. So with that, I will take any questions. I just want to thank Dick Epkiss, who's in Leiden and has been my European counterpart for the International Registry, Wayne Teresky and Helena Gardner for their lively debates on this subject, and of course, Abe Rudolph and Katie Archbold, an administrative analyst who has been key in keeping the registry going. Thank you.